Okay, let's continue with it. Next we have so I've already discussed this. Easy. Identify the type of categorical agreement. So as I mentioned, just put susceptible, intermediate, resistant. If there is sensitive to resistant, so if your new AST method is saying sensitive but it actually reference method is showing resistant, this is a very major error, because just remember, it is a clue. If you're giving sensitive report, clinicians are most likely to start this drug, so which is actually a resistant drug which will cause more harm. So that's why it's a very major error. Whereas if it is the new AST method is giving resistant but the reference is showing sensitive, that is, there is a difference of two steps, so this is your major error. Now if next any other permutation combination, that is only one step difference, sensitive to saying as intermediate, sensitive by new method and reference method intermediate, or intermediate to resistant, or vice versa, that will be your minor error. So we have resistant here and intermediate here, so this will definitely be a minor error. Next, a 48-year-old man resides in a hematology ward following a stem cell transplant procedure. This treatment is for AML. His regular medication include acyclovir, cotrimoxazole and posaconazole prophylaxis. He develops fever and shortness of breath. Chest radiograph shows focal density in the right upper lobe. The CT scan of the chest shows a large nodule in the right upper lobe. And blood Aspergillosis PCR and galactomannan are both positive. The medical team has started him on broad spectrum antibiotic, empirical antibiotic. What other treatment would you like to add? So this is a suspected case of invasive pulmonary aspergillosis, as I have discussed in my previous webinar. So IPA you will be thinking of when the patient is satisfying host factor mycological criteria or your radiological or clinical criteria. So your host factor here, the patient is having AML and is a HSCT recipient, hematopoietic stem cell recipient. So this will satisfy the host criteria. Then mycological criteria, we have blood Aspergillus PCR positive as well as galactomannan which is positive. So we have the mycological criteria. Then radiological criteria, we have the large clinical features showing fever, shortness of breath, chest radiography showing right upper lobe focal density. So all these are it makes this a case of probable IPA. So whenever a patient is having probable IPA, the drug of choice for invasive aspergillosis is actually voriconazole. But if you see in the history, the patient has been on a posaconazole prophylaxis, yet he has developed an infection. This is suggestive of this is what we call as breakthrough infection. So whenever we are dealing with breakthrough infection, until we have the species of aspergillus or the with the AFST, it is necessary that you give another class of drug. So here obviously voriconazole or isavuconazole we won't be giving. Will you be giving micafungin? Echinocandins has no role in treatment of aspergillosis as a monotherapy. There can be in case of combination therapy, but not obviously as a monotherapy. So here the answer is amphotericin B. Which of these patients would be appropriate for fluconazole prophylaxis in an intensive care unit? Let's examine each scenario. A 34-year-old patient treated in ICU for severe influenza and associated bacterial pneumonia. Sputum is suctioned from the ET tube and subsequently this grows Candida albicans in routine culture. So whenever you're seeing respiratory sample having Candida, always whether it is with this BYC with pseudo hyphae or what Candida pneumonia is a very rare entity, and it is usually diagnosed on HPE, and it is so rare that in a case where they have examined in 10 years, only 5 cases out of some 350-400 cases had actually Candida pneumonia. So we are over-diagnosing it, and in respiratory sample, always and always ignore your BYCs unless and until it is Cryptococcus. So obviously in this patient we are not going to treat with fluconazole prophylaxis. 72-year-old patient treated in ICU for a flare of glomerulonephritis. They are receiving high dose methylprednisolone. Your steroids are a risk factor for your mold infections like your Aspergillosis, including your mucor. Candida, not so much. So no. A 56-year-old patient treated in ICU post-operatively following a hemicolectomy procedure. The surgery was complicated and the surgical team are concerned about the leakage at the site of anastomosis. So when we see your gut is one of the area where Candida is a commensal, so definitely this is a risk factor. The surgery was complicated and there is some leakage in the anastomosis. So this is an ideal situation where fluconazole prophylaxis can be given. Then in the last case, a 38-year-old male treated in ICU for severe sepsis secondary to a urinary tract infection. They are catheterized for urine output monitoring. A urine sample was taken at the time of admission which isolated E. coli. The catheter urine sample is taken for reassessment. This isolates Candida albicans and no bacteria. So I agree, ICU patient, severe sepsis, secondary to UTI, everything, this clinical scenario is fitting. But if you see, initially there was E. coli, but then later E. coli has disappeared, but Candida is persisting. This could also be the colonization on the catheter. Candida is usually a colonizer over the catheter. So ideally you have to repeat and look for whether it is persistent or not. So this is not a candidate for your fluconazole prophylaxis. Next question, identify the type of resistance. So the organism here is Pseudomonas aeruginosa. So whenever you are seeing this, so you are seeing ceftazidime resistant, cevipan resistant, peptide resistant, imipenem sensitive but miro resistant. So this can happen when, usually this discrepancy is noted whenever there is an efflux pump. So this efflux pump is pushing out the meropenem. That is why meropenem is coming as resistant, whereas imipenem is coming as sensitive. And when will you suspect porin mediated resistance? So whenever you are seeing a weird report where your BL and lower BLBLI like your ceftazidime, cefepime, peptide is sensitive, whereas your carbapenems are resistant. So this could be the porin mediated resistance. So in Pseudomonas, apart from your carbapenemases, carbapenem can be resistant by non-CPE, that is non-carbapenemase enzyme producing resistance, which includes your porin as well as the efflux. This can happen. Can happen with enterobacterials as well, but in Pseudomonas these resistance are supposedly more common in the Western world. But in India again we have the more of MBL type of carbapenemase producer. Next question, a family of 3 test positive for H1N1 and is commenced on treatment. A 4th member with renal transplant on immunosuppression is asymptomatic and is in contact with the family. The recommended treatment is, so whenever we are dealing with influenza in a transplant or immunocompromised host with the renal transplant, so the ideally thing is you have to give seasonal annual vaccine, influenza vaccine, that is the recommendation. And in case there is an exposure, there is no requirement to give any treatment as such. You will observe the patient. If the patient is developing any symptoms, then you will do the isolation and oseltamivir after the throat swab. There is no role of prophylactic oseltamivir, or there is no role of giving dual therapy prophylactically. Next question, a 22-year-old presents with history of fever, 7 nerve palsy and cervical lymphadenopathy. Additionally, she has a morbilliform rash that presented after first dose of augmentin. She has seventh nerve palsy and worsening urinary incontinence. A monospot test for infectious mononucleosis is negative. So what is her likely diagnosis? So fever, cervical lymphadenopathy with a morbilliform rash after first dose of augmentin, all are in favor of your EBV infection causing infectious mononucleosis, but a monospot test is negative. So for this you need to understand the sensitivity and specificity of a monospot test, as well as the when you should order what test. So the first test, or the first antigen which appears is your VCA, that is a viral capsid antigen, and your monospot test or the Paul Bernal test, which detects a heterophile IgM of the EBV, it appears usually later along the course of usually after 5 to 7 days. So if you're doing in the early phase, this can be negative, which can lead to for the false negative results. So that is why you need to know what test to order at what part of the illness. So here, though all monospot is negative, it could highly be your infectious mononucleosis. Staph shock syndrome, the patient is not exactly in shock, and transverse myelitis, the other features are not fitting. Lymphoma, again tender lymphadenopathy, and rest of it is not fitting into the diagnosis. So it is infectious mononucleosis. Next, a 36-year is brought to emergency in comatose condition. Her examination reveals multiple crusting skin lesions on the trunk, arms, left breast, and left breast has crimson red appearance. CSF analysis reveals meningitis, left shoulder and right hip osteomyelitis, and multiple pockets of abscesses in the chest and abdomen. So till here, if you're just thinking this patient could be a case of your Staphylococcus caldid skin syndrome, or it could be a TSS, or secondary to your staph or step, that is your mostly your gram positive bacteremia having so many abscesses, osteomyelitis, widespread infection including meningitis. But when you read further, her only significant medical history is presence of left breast implant surgery 6 weeks back. So whenever you're thinking in this line, so your NTM bacteremia becomes more likely, and you will have to look for it. Usually it is the Mycobacterium fortuitum usually which causes such infection in case of implant surgery. Also, when if the patient is having any history of tattooing, etc.